Okay, so chapter 48, inflammation. So by the end of this lecture, you'll hopefully be able to compare the side effects, contraindications, interactions, nursing interventions for patients taking biologic therapies and non-biologic therapies, planned nursing interventions for patients taking disease-modifying and anti-rheumatic drugs, or DMARDs. This is chapter 48, but this is only rheumatoid arthritis, okay? So what is rheumatoid arthritis? Rheumatoid arthritis is a systemic autoimmune disorder. It's characterized by the disfigurement and inflammation of multiple joints. You've probably seen people with rheumatoid arthritis. It's not always as advanced as some people with like advanced arthritis where their fingers turn different ways. I've known people with rheumatoid arthritis that have no physical abnormalities that I can see with my own eyes. It's like deep in their knees or their hips or their it's in deeper joints that you don't always see, okay? But it's constant inflammation in these joints, so it's painful when they walk. It's painful when they do anything, okay? So these they have rheumatoid factors, which are like autoimmune antibodies for rheumatoid that activate the inflammatory response in the joints. This can actually lead to like infections, pulmonary diseases, pericarditis, and other systemic infections, not just joint inflammation, sorry. So the initial treatment's always NSAIDs because it's arthritis, okay? NSAIDs, reduce the inflammation. Once the NSAIDs stop working, they'll switch to corticosteroids for more severe inflammation. And then when those aren't working either, they switch to the DMARDs, okay? So the DMARDs are like usually infusions or sub-Q injections. They're not really PO meds very often. A couple of the non-biologic DMARDs are PO, but these are more systemic effects. They're more they decrease your inflammation, and we'll talk more about them. But a lot of these take months. All of them take months for them to start working. So we've got to build up using them because, like we said, it's not going to be immediate, okay? So we have our non-biological DMARDs. So these are your non-biological DMARDs. The first one is azathioprine. So almost all of these have some kind of effect on your the inflammatory cycle. So these are non-biologic, so they're not something that's going to look similar to your body. It's going to be something else. Okay, so they're not going to block a certain type of inflammatory factor. They're just going to help reduce the inflammation by usually suppression of your immune system. Almost on both slides, they reduce your immune system. Okay, so we have chills, fever, malaise, myalgia, myelosuppression. All those kind of go together. Once I have myelosuppression, which is like bone marrow suppression, it's when my immune system gets suppressed. I have fever, chills, malaise, and myalgia. Those are all symptoms of like infections and just not feeling great. Okay, so those are pretty common. That makes sense, right? It's hepatotoxic. And then it's lymphoproliferative disorder. So that's when your lymphocytes actually make too many lymphocytes. And you're thinking, well, that's the opposite of myelosuppression, but it's not. That is still not an active and competent immune system. Okay, if my body's making too many lymphocytes, they're not working. Not all of those are perfect. That means I have like these dysfunctional lymphocytes trying to run around and kill stuff and help fight infection and stuff, but they're not going to work because this is not helping. So then we have hydroxychloroquine. This medication's used a lot of times with blood disorders or for immunosuppression. This would also has anorexia, nausea, vomiting, headaches. It can have you can have aplastic anemia, personality changes, retinopathy. Retinopathy can cause blindness. So it's a condition concerning your retina, and if it goes untreated, it can actually lead to blindness. So keeping your regular eye exams and making sure that they see any kind of vision changes, they tell their doctor, is important. Agranulocytosis and seizures. Aplastic anemia is similar to anemia, but where anemia can be based from like iron deficiency, this one cannot. This is only from bone marrow suppression. Okay. So the other thing with that is if you have aplastic anemia, you may bleed easily. So we talk about it a little later, but the soft tissue toothbrushes. You know, we're gonna tell them to monitor for bruising or bleeding or things like that. So then we have leflunomide. So this one, you have diarrhea. It can elevate your liver enzymes. It is also hepatotoxic. You have alopecia, rash, and of course, immunosuppression. Methotrexate, which we know all about because we've studied it in cell reg by now. So this one, of course, you can have the gingivitis, the glossitis, which is inflammation of your tongue and your gums, mild leukopenia, nausea, ulcerative stomatitis, myelosuppression, aplastic anemia, liver cirrhosis. So yeah, it says it doesn't say hepatotoxic, but that is still damaging your liver. Okay, so it's still liver dysfunction. It's not good. Nephrotoxicity, which affects your kidneys, pulmonary fibrosis. So pulmonary is in your lung. Fibrosis means it becomes fibrosis condition. I'm sorry, osis is a condition of fibrous. They become hard. So pulmonary fibrosis, they become more stiff, and so it's harder to breathe. That's a big deal. Obviously, I don't want my lungs to be stiff because then they can't expand and I can't breathe. Okay, so telling this patient to, they can't get pregnant because we know we use it to terminate ectopic pregnancies, telling them about the kidney and the liver and the pulmonary side effects, telling them about the myelosuppression. So like with all of these, I don't know if I said this already, but we have to avoid avoid crowds. We need to monitor CBCs because we have to make sure that our white blood cells, our red blood cells, leukocytes, neutrophils, all those things are normal. And we have to tell them to avoid crowds, avoid sick people. Like this is when you're being immunosuppressed, you have nothing to protect you. So one person has a cold and you're like, oh, it's nothing. And then it's a full-blown pneumonia and worse for you because your body cannot even fight the simple cold. Okay. And then we have sulfasalazine. So this one, again, headache, anorexia, nausea, vomiting, anaphylaxis, Stevens-Johnson syndrome, and agranulocytosis, leukopenia, and then reversible oligospermia, which is a reduced sperm count. So that means it'll stop after you stop taking the medicines, the sperm count will come back up, which could lead to infertility, especially if you're trying to get pregnant, if you're trying to impregnate somebody. So all of these meds except hydroxychloroquine are hepatotoxic. So we better be monitoring our liver enzymes, okay? Monitoring our CBC because these all have some kind of suppression, whether it's red blood cells, whether it's white blood cells, neutrophils, leukocytes, something, okay? Monitoring our kidney function, especially for our nephrotoxic drugs, but also this is how most of them are excreted. Good oral hygiene for the gingivitis, okay? So we don't want to make it worse. Hydroxychloroquine has to be taken with food or milk. And once again, all of these drugs take months to work. They are not fast acting. So then we have our biologic DMARD. So TNF is over TNFs or non-TNFs. So when you block TNF, it is a enzyme that is released to promote inflammation. So when we block it, you won't have inflammation. These are horrible names to remember, okay? A lot of them end in CEPT or UMAB, okay? They have so much easier trade names, but I'm going to try in a minute, okay? So the first one, the TNFs, these, a lot of these are sub-Q, some of them are IV, but these are sub-Q injections, so the local reactions to the injection site, that makes sense, right? If I'm suppressing inflammation, or if I'm, immunosuppressing someone, they may have actually like a rebound effect, like just as soon as you poke them, break the skin, it turns red and it wants to try to get infected, and it's really not, it just might be red or painful or things like that. Then the rest of them, all the way down to heart failure exacerbation, are all different types of infections, okay? Infectious related problems. So it obviously, it causes neutropenia, which is the last one. Stevens-Johnson syndrome and increased malignancies. So we have to monitor for signs and symptoms of infections. That's a fever, a cough, a productive cough, any kind of drainage, any kind of anything. You're doing full head to toe assessments on these people and you're making sure they don't have any infections that you can see, okay, or hear. So we definitely want to monitor the site, making sure the site doesn't get infected either. We want to tell them about how to avoid people with infections and things like that. We want to monitor their CBC, okay? For the non-TNFs, these block the interleukins in the inflammatory pathways. Once again, local injection site reactions, okay? The nasopharyngitis, neutropenia, a bunch of infections. I'm not going to get into. Two of them, the two right here have increased malignancy, so you have an increased risk of having some kind of tumor cell. You can be allergic to it. You can have hypotension with the rituximab. Also with the rituximab and these other ones, you can have bowel obstruction and perforation. So you have usually these meds cause really bad constipation that can lead to the bowel obstruction. So we're making sure that we're monitoring our bowel function, like our bowel movements, monitoring the the bowel sounds to make sure you don't have an obstruction, because that's the first one. You wouldn't have any bowel sounds. Perforation looks like extreme pain, and then when it's like out of nowhere, it just kind of happens because it just pops. That's when there's a hole in the colon or in the stomach. The other thing is we want to tell them how to combat this constipation, whether it's increased fiber, whether it's increase your water, have a certain kinds of diets or medications, whatever works to make sure that you're regular. We want to monitor the site, monitor for some symptoms of infection, and monitor their CBC. Okay. With so now we're going to get into Humira. Okay, this is adalimumab. If I say it really fast, it works. But Humira is much easier to say, and you've probably seen it. You've seen commercials for it. It's all over TV. Okay, this is a sub-Q injection. They use it for all kinds of arthritis, all kind of inflammation like Crohn's disease, ulcerative colitis, psoriasis. Okay, so it's not just for RA, but it blocks TNF, which is a key enzyme in inflammation. Okay, the onset is 4 to 5 days. So you're not even going to see maybe a little bit of an effect until 4 to 5 days, maybe even months. Okay. Once again, you can have injection site pain and then reactions. Okay. You can be red, sore, of course. Upper respiratory tract infections, increased creatine phosphate, headache, and rash. There's a couple black box warnings. One of them is an increased risk of serious infections and malignancies. If you have latent TB or latent Hep B, it can become reactivated while on this medication. Leukemia, lymphoma, and some malignancies have been reported. And then fatal hepatosplenic T-cell lymphoma is rare, but has happened. Okay, so definitely some black box warnings we want to warn people about, right? We're going to avoid anakinra, Aticept live vaccines because we're immunosuppressed and we don't need any form of a vaccine that's alive, coming at me. Other immunosuppressants, we want to avoid those as well because we don't want to suppress our immune system even further. Echinacea, we want to avoid, and there's supportive treatment for the overdose. So if I overdose, it's like you wouldn't really have like a specific set of symptoms. It's different for everyone. So we just support whatever's going on. There's no real contraindications. Once again, this is a sub-Q injection administered every other week. When you have to teach your patient how to do this, they have to show you that they know how to do it before they can leave. You can't just say, okay, you just inject this into your stomach, because they have no idea what to do. Remember how long it took us to remember to do that, okay, and get the courage to do it. Imagine doing it on yourself. So they need to be able to repeat the steps and show you how to do it, okay? You're going to tell them to store it in the refrigerator, but warm it up before they inject it, okay? So it can sit on the counter until you inject it, but that's it. It's just when it's really cold, it burns really bad. Once again, all these are immunosuppressants, so we're going to monitor for infections. We're going to monitor for malignancies. If they have any kind of odd symptom, odd pain, odd growth somewhere, they need to go have it checked out, okay? If they are before they start the treatment, you need to check them for latent TB and Hep B. Another weird thing is that the needle cover actually may contain latex. So if you have a latex allergy, we may have to monitor you or tell you not to touch the cap, find a way to change the needle or something like that. And then also we told them about how to give the injection. We have to remember how to tell them to rotate the sites. That is all. There's not much to it. It's a lot of very long, ugly names, but a lot of them have the same side effects. The most important thing is with all of them is that they have some kind of immunosuppression, so we need to monitor for infections, okay? Read your book if you need to, study the drug cabinet, just post questions if you have them. If you need anything, just email me, and good luck.